just put your chin there for me. Okay, also you can close both of your eyes for me. Okay, open for me now. So I was looking at the lashes, just looking for any anterior blepharitis. Now we're looking at conjunctival redness, pterygiums, pendiculars. You can look this way for me now, Obi. And this time, I want you to just look where my ear would be. Just look up for me. So I'm now looking at the Meibomian glands and looking to see if they're blocked. And you can see that we're going to have a little bit of fun just now. Look down for me. It's really not too bad, but you can definitely benefit from the sessions. And one thing is that computer, because we stay and we don't blink, definitely worsens the condition. Okay. So for the left eye now, I'll virtualize shortly. Just look down for me. Close for me. That's what I meant. Okay, open, and to that side, you already know what to do. A little bit of binocular. Is that giving away confidential info, Obi?
No, they diagnosed me a while ago.
Yeah, okay, good. So my patient's least favorite part, just look down for me. This is a huge deal for me. I think that every single, just look down again. Every single optometrist should be doing this on every single patient. Especially your kids, you just want to make sure that you don't have the start of an allergy. I can see you don't like this test, Obi. Just look down for me. That doesn't look too bad. I take it you're not an eye rubber.
Absolutely not.
Thank you. You can look down. So you can sit back now.
If a person, let's say you already knew that they come for a normal eye exam, and then you pick up dry related signs and symptoms. Do you book them separately for a dry eye workup, or do you then include it as part of the examination that you're doing there? Especially, let's say it's a first timer, or first time patient, who you told them that the eye examination was X amount, and that's what you advertise. That's what they know, that the eye examination costs X amount. And now they are here, but from the case history, communicating with them, doing your initial diagnostic procedures, you pick up that, you know what, you're going to actually need to do a full dry eye workup in this case. How do you then introduce that conversation to the patient?
So I would definitely still do fluorescein, because I want to see what that cornea looks like. I want to see what that tear breakup time looks like, and that's just what I'm used to. But then I'm going to have to book them for a separate workup, so that I can do listening, I can do shimmer. And on that session, after the workup, we're going to start with one procedure and then book them for the next week.
So then, on that first appointment that they came for here, do you continue with the rest of the examination, or then do you change your approach completely for that particular patient?
So I would continue with the examination as is for their glasses or contacts or whatever. If it's really bad, if there's a lot of blocked glands or a really bad anterior posterior bleph, then I would treat them first. And if sometimes you might even find changes in refraction, so you might have to even hold on for a pair of glasses and do this first and then see them again. But one of the things I wanted to say to you is a way in which to introduce it to them, and it's a really, really, really nice topic because it really brings in the clinical side. And the thing that I like to tell patients is that we all have bacteria that's within our eyelids, and what that does is it causes a film on the lids called biofilm. And what research does is it actually compares that to plaque on teeth. So the same way that you have to brush your teeth every single day, similarly you need to then have a daily routine of eyelid hygiene. And so obviously you're automatically selling them a product which they need, but once they come to the sessions, at the end of the 4 sessions is a little bitty bag which entails a mask, because you've got to use the mask once a week, and it entails eye drop as well as an eyelid cleanser, whether it's a spray or your Crescenti wipe or your Alcon wipes, Navy Black, whichever it is that you as a practitioner prefer to use. Okay. All right. So what we're going to do is fluorescein. Okay. And I'm sure that most of us are quite familiar with that. Unlike the lissamine and the shimmer strips, when I got the boxes, I looked at it and it was kind of daunting. Okay, I'm going to ask you to look up. Your head can stay forward, that's fine, just look up. So fluorescein is a little bit of an invasive test anyway. It's sometimes better to put it at the bottom. Otherwise you kind of breaking up that tear film anyway. Look up for me. But you don't always have such good patients like you. And sometimes it's easier if they just look down. So I'm going to get your chin back there, forward against the bar. And it's already set to our blue light. With glycerine though, we're going to evaluate with white light.
Okay. Now why is that the case?
Because that's how we need to see the stain. We use white light. We don't need the cobalt filter. Okay, look where my ear would be. I'm going to ask you to blink once and not again after that, okay? So blink for me, open, don't blink again. And let's look at this side. While looking at the breakup time, I'm also taking note of the tear meniscus. And it's going to be interesting to compare what I think it is to what the shimmer test is going to show me. Okay. So it looks a little bit low, but let's see what shimmer shows me. You can sit back. So, do you have a bit of a dry eye? Because initially I counted about like instant, but then by the time we had to redo it because of the car and everything, it was like the dye was just gone.
Yes, I do have. I'm one of those patients that I have something, but it doesn't. When I've got my glasses on, everything is working perfectly for me personally.
Yeah.
It's only when I'm not wearing my glasses specifically and I'm working long hours in front of a computer, of which on a normal basis I'm spending anything from 12 to 16 hours per day in front of a computer. So, but once I have my glasses, I'm comfortable.
Yeah, do you have a blue control filter?
Yes.
Okay.
Yes.
Yeah.
And I don't know, sometimes I've got multiple pairs of spectacles.
Yes.
And after a while, I think I can pick up that, okay, I see better with one pair as compared to another pair that might have different coatings on it, just depending on how long I'm using it for. But from a dry eye point of view, it's not something that I'm complaining of.
Yeah.
Because I think for me, my seeing problem personally is bigger than my dry eye related problem. So I think that's just me specifically. I don't know if that helps you anymore.
Yeah. Alright, so I'm just going to record what I found there.
Hameeda, so what are we doing now? What is that? I see that you have a lissamine strip with you. So what are you going to do with it?
Okay, so the lissamine strip is to show any conjunctival dryness. Okay. And lid wiper is actually a really hot topic in optometry right now.
How so?
So the lissamine strip is going to show if there's any staining on the conjunctiva, and particularly show this green line that you're going to find in the lid, which is a deadening of your epithelial cells.
Okay.
And the sessions that we're going to do are meant to actually get rid of the lid wiper, because that causes friction between your eyelid and your globe, which is causing dryness. And obviously in a contact lens patient where you find that they have a decreased lens tolerance, it could be because of lid wipers. So that's why the sessions are so good for these type of patients. Okay. So the workup's done in your first visit, and then we do a session. We then do another 3 sessions, and obviously a workup at the end of the last session, so that we can look to see if there's any improvement in these types of staining. Okay, so I'm going to put this in your eye now. This one, it's a little different to fluorescein. It has to be, you've got to kind of let it soak a little bit longer.
Okay.
In your saline or your solution. You're not always going to find a stain. So I'm just going to wet it and let it kind of sit there for a bit.
Okay.
Before I actually put it in your eye. And if I have to put it into your left eye, I can use the same strip, but I've got to wet the strip again. Okay.
You said there are 4 sessions.
Yes.
And do you educate the patient from the onset? So in essence, that's like 5 times that the person would have come in. It would have been the first normal eye examination that they came.
Yes.
And now you're going to tell me that I need to come here for 4 other times. And
yes.
How much time do you book for that? And are there any cost implications involved in me coming all the time? And like, how does that influence the day-to-day operations? And if you've got 4 patients with similar problems, because obviously I'm going to make the assumption that this then becomes something that you're going to get a lot of referrals on.
Yes.
If one patient is happy with the results,
yes.
they're going to tell the next person.
Yes.
And that person is going to tell the next person.
Yes.
So how does that influence your operations here then?
Can I call a friend? Because I have no idea how long this takes. I told you, you're my guinea pig for today.
Okay.
Okay, chin there. So like I said, I'm going to go back to the white light. And the listening takes a little bit longer to absorb. So, you know, it was a good thing that we could chat a bit. Just look to the side for me. It actually looks pretty good. Just look to the other side for me. And remember that your listening stain is for the mucin layer, hey? The goblet cells. Remember your 3 layers of your tears. So just look up for me. This looks pretty good. I'm going to invert the lid because I want to look to see if I do see any lid wiper. So just come a little bit forward for me. And just look down again, and yeah, overall that looks really good. I really don't see a stain, which is fine. You know, it's okay to find that you don't find any staining with your listening. You can sit back. Okay, just put your head back for me. And I'm going to put a drop, just a drop of anesthetic. It is look up again, so head back. I'm just putting a drop of anesthetic in the eye. So the reason I put anesthetic in the eye is because I wanted to eliminate the reflex tearing. So we're just going to wait about 2 or 3 minutes, and then once the eye feels a bit numb, we can put the shunt strip inside. Okay, and we're looking at your basal tears, and we're looking for aqueous deficiency here. You know, I think that evaporative type of dry eye is more common, but I think it's important to do this test for the workup because a lot of autoimmune conditions will have a decreased aqueous layer. Okay, so now look up for me. After the anesthetic is there, I am just instilling this towards the nasal side. Nasal or temporal is fine. I just want to get a little bit away from the cornea. Just close for me, and you're going to keep it closed. And we're looking at about 5 minutes. I think I said 7 minutes earlier, but we're looking at about waiting 5 minutes and then to see how much of your tears actually wet that strip. Because it is with anesthetic, shimmer 2, I think we're looking at a norm of about 10 or 12. On a good eye, it's not impossible to find a little bit more than that. It's you know, we're obviously just looking for the bare minimum right now. So I think after 5 minutes, anything that is less than 10 or 12 millimeters is going to indicate that you do have a bit of an aqueous deficiency. How does that feel? Perfectly fine with the anesthetic, of course.
When are you putting the strip in? No, I'm being serious. I can't feel anything.
Of course, of course. And another thing that I want to say is that, you know, we shouldn't assume that the tear layer is going to be the same for the 2 eyes. So I would do this to both eyes for the patients, because you can't just assume that the result is going to be the same, you know. I remember when I was at one of the hospitals sometime last year, the ophthalmologist actually showed me where the tear layer was perfectly normal for a patient, and in the other eye it was actually a lot lower. So Obi, if I'm doing this on a patient, I'm going to put the shimmer strip in both eyes so that I can record separate measurements, you know, just like listamine, just like fluorescein. I'm not going to just assume that I'm going to get the same result, you know, between the two eyes. Okay, I'm sure with slit lamp, if you look at the tear layer, you can sometimes find in your patients that you might have a normal tear layer on the one side and maybe a slightly reduced tear layer on the other side. So it's always a good confirmation and, you know, kind of do it on both eyes. Okay.
I wanted to ask you, if I am a contact lens wearer,
Yeah.
and I have these dry eye challenges and you need to do all of this,
Yeah.
when should I take off my contact lenses when I come to you?
On the day is actually fine.
Okay.
So I'm not going to get somebody to come out of their contact lenses unless I'm seeing a bit of GPC, you know, which indicates that they need to reduce wearing time or cease contact lens wear or change brands or something. But other than that, you know, if you just come on the day with your glasses, I don't see any issues with that. Open for me. Look up. Okay, so we are looking at about 7. And the normal is about 10 to 12 millimeters. Okay, so I definitely think we're dealing with an aqueous deficiency, which is a nice twist to all of this, because you know, these sessions do really well for Meibomian gland dysfunction or for you know, a bit of posterior black where the glands are blocked. So I think if you're using artificial tears, I would go with something like Optive Fusion, because of the or the Sustain Ultra, because you know, the ones that are not oil based.
Okay.
But I did see a bit of an evaporative type of component as well when I put the fluorescein in. So using a combination drop like the Sustain Complete, I think it is, might actually do really well. But I would dive in and do these sessions anyway.
So let's actually book
Yeah.
time, proper time,
Proper time.
and
Yeah.
actually do the
Actually
whole.
do. Yeah,
Well,
maybe what you could do is visit Mariki for the second session and then complete the sessions here or something to that effect. So now what we're going to do is we're going to actually start the session, and I'm going to go over to that side and put the mask in the microwave,
Okay.
and then I'll be back. So I'm going to remove the mask now. The 10 minutes are up. I'm going to start with the alga brush with a cotton wool tip and buff the eyelids. The next step is that I'm going to use a debrader to scrape off that sort of biofilm that we spoke about. And then I'm also going to then use a pedal tweezer to express the fluid out of the glands. Okay, just close your eyes for me. I'm spraying some of the IQ eyelid cleanser onto a cotton wool pad and just cleaning your eye. And this is a really good product for blepharitis and dermadax. You know, it kills 99% of germs, and it's really doing quite well.
These tools that you've been putting or using in my eye now,
Yeah.
how did you sterilize them? Yeah.
So I sterilize it in hot water, boiling water, once a day. And before the patient, I also put it in the UV unit after the patient.
Okay.
And before the next patient, it's an alcohol swab.
Ah,
Hot water at the end of the day again.
okay. Perfect.
So Obi, that's basically the gist of the procedure.
Wow, it's so interesting the fact that you did all of this with a slit lamp.
Yes.
You know, it's so amazing how you have showed us what's possible with just a slit lamp. And majority of optometric practices, this is that one piece of equipment that they have, and this is the one that will cost the most. All these other things are actually cost effective for everyone to actually start expanding their clinical skills and start treating dry eye the way we're supposed to be treating dry eye. So, and from a patient point of view, actually, it was actually pretty cool. I got the sense that I was getting confidence in what you were doing.
Yes.
Because one thing, a lot of optometric practices don't do this. So even when you're a patient sitting here, I know that patients are going to be feeling like this optometrist is putting in effort
Exactly.
in solving my problem.
Yes.
They're not just writing some script
For an eye drop.
for an eye drop or telling me just go to the pharmacy to get an eye drop, but they're actually invested in me not only seeing clearly, but having comfortable vision in whatever that I'm doing, you know. So
Yeah.
I'm excited for how this is going to turn out.
Yes.
And it will be good for us to do a follow-up with you
Of course.
in a couple of months when you've been working with or doing this with a lot of patients and actually see how that is actually impacting your practice and their vision within the community. So yeah, man.
Yeah, I look forward to that. This was really fun. I thoroughly enjoyed it, and really thank you so much, Obi, for recording this with me.
This was quite fascinating for me experiencing it, you know. And that's the thing that we need to always remember, that before we start doing things for patients, we need to experience it ourselves as practitioners and get our teams to experience it. And I'm excited. This was actually quite fun.
Yeah.
And I'm excited.
Amazing.
Thank you very much.
You're welcome. You're really welcome.